Hey everyone, I want to say welcome to this documentation tips where we are going to be talking about how this recent case should make all therapist providers. It doesn't matter what your title is, it doesn't matter if you are in grad school, it doesn't matter if you are studying for the exam. This particular case trial that some people are following, some people don't know about. I would highly recommend that you get your note and paper. And so I decided to make this a free masterclass before we get started because I am live streaming. I do want to make sure that you all can hear me okay. And so, one, let us know where you're tapping in from, but put a one in the chat box just so I can make sure that y'all can hear me good. Okay. And so, I want to say welcome. My name is Dr. TK, licensed clinical psychologist and therapist, business coach, and mentor. And today we are going to be talking about how to protect yourself as it relates to documentation. All right. So let's go ahead and get started. I am going to queue up my screen. If you have any therapist friends that you would like to invite over, I would highly recommend. This will be available immediately upon replay, but if you want to ask questions or provide some insight, I would highly recommend for you to stay throughout the whole thing because I also have a bonus that I will be talking about later for you, especially for those of you who's showing up today live. And so let me go ahead and queue up my slides. I just want to make sure that y'all can hear me good. And let's go ahead and get started. All right. Let me make sure my mic. Okay. Mm-mm. Okay. So y'all can see that? Cool beans. I'm looking at myself on the other screen too to make sure that I can see myself because that means that y'all can see me. All right, so let's go ahead and talk about it. I will also be sharing a case study that relates to this particular topic. And so let's go ahead and jump into client notes. I'll call it Therapist Be Ready. That is just my way of saying that, this is a topic that I talk about all the time in terms of operations, productivity, and making sure that you don't slip through the cracks. But we get comfortable in private practice, so we're gonna go ahead and start talking about that too. So, a note before we start: I always like to give disclaimers, and so I am a licensed clinical psychologist located in Southern California. I am not commenting on any specific provider because I know this case involves providers. I'm not making any specific comments on the patient, the individuals involved in the case, rest in peace, and or the case outcome. I have no clearly insight knowledge and I'm not diagnosing anybody, so I'm not going to give, and therapists shouldn't be doing that anyway according to APA ethics. We should not be diagnosing someone we've never seen. Also, everything referenced today is already public knowledge. This is simply for the public and for therapists, actually, because the public can listen to this too. This is psychoeducation. It is not legal or clinical advice, but you should pay attention. And what we're going to be diving into is why therapists don't need to be getting comfortable. Okay. And so I want to start this off by highlighting a particular case that mirrors the subpoena process. And so earlier in my career, when I was licensed, I was working in a juvenile facility in LA County, and I was called into my program's head office. That's like the dean of our facility, okay, under mental health. And it was in a juvenile justice camp facility. And when I walked in, my supervisor was already sitting there. And so, what would be y'all thoughts if you walked into a office, you don't think you've done anything wrong, but you do know that you worked in a jail. You do know that at any time, these kids, these minors, their charts can be subpoenaed at any time. But you also know that you're dealing with a lot of moving pieces in terms of the court system, right? And so most people are going to feel nervous. And so I'm going to tell you what happened with that case after we talk today. But the reason why I'm introducing this case, especially coupled with this particular trial that is happening, is that while the trial is happening, it does involve information about telehealth sessions, which is the world that we live in. It also talks about, which I will not touch upon, that is not my expertise, is psychiatry and medication changes. And then also the case brings up what records were or were not reviewed before a tragedy occurred. Okay. So again, I'm not commenting on anyone else's care. I was not personally in the room, but the question that I want you all who can comment back and or, just think about it is the question for all of us as providers is if your chart got pulled tomorrow into court, would it hold up? That's the question. If somebody asked for your chart right now and it got pulled into the judge's chambers, would it be adequate enough? Yes or no? Okay. And to be real, a good amount of therapists may say it depends. And we're not going to get into that, but you know your documentation style. And so let's address my private practice owners, group practice owners, contractors, those who pretty much, you know what I'm saying, you call the shots. And so therapists, this case has highlighted how too comfortable we have gotten. Would you agree? So think about it. You've spent months or years in your business or private practice. What starts to happen over time, and low key, this happens to people, unfortunately, at all types of jobs, is that your job becomes too normal, where it starts to be on autopilot. What starts to happen in mental health is that you know your population so well, probably because you've niched down and you cater to, let's just say, one big presenting problem, and then that breaks down into, other detailed problems. But you know what questions to ask. Usually, you sometimes can even jump the gun in terms of how treatment is going to flow based off of the presentation during the intake process. Sometimes, unfortunately, I hope this is not the case, but do some therapists stop saying some things or asking some things because you may already have a feel, right, of what the person in front of you is feeling or thinking? Now, I really hope that is not the case, but I really want you to evaluate yourself, right? And so I want to highlight that, some people will call that lazy, some people will call that unethical. But what we call it is autopilot. That is an experience that you're having in your own business by doing probably the same thing with different clients over and over again into a shortcut. So I'm not going to call it lazy, but I'm not going to like let you off, right? You have learned how to shortcut the process, which may come back and low key slap you in the face. Okay. So this is the moment to ask yourself, I'm going to show you a list and I want you just to think about it. Which questions or areas have I stopped asking on autopilot? I'm going to say that again. What sections or questions have I stopped asking on autopilot? Okay. So this is not an exclusive list, an exhaustive list, but some of these categories should look familiar if you've been trained. And so, which of these do you miss? You can put any number in the comment box. Client identifying information. It is not just your name, birth date, and race. Okay. What is the presenting problem in detail? When we do psychological assessments or intakes, we should be, for every symptom that they mentioned, we should be looking for the onset, the duration, and the frequency. Let me say that again and write it down. Onset, duration, and frequency. So if somebody says, I'm gonna go back to the jail. If a kid says, I can't sleep, I'm going to ask them, when did that start? Because I'm trying to figure out if it started just because they're in jail or did they have that problem when they were at home? Now, if they have that problem when they're at home, clearly when I get into the psychosocial history, I'm going to start paying attention to their home environment. What's going on outside? Is it helicopters, right? Duration. How long has this, been going on in terms of like lasting? If they say like, I wake up in the middle of the night, I'm looking at frequency. How long do you stay up and how many times a night do you wake up on average out of 7 days a week? Why am I asking all those particular questions? And the public, y'all need to hear this if you're listening as well. The reason why we're asking so many detailed questions, because all of these responses lead us to, if it fits, the proper diagnoses. If we get the proper information and we link it to a diagnosis, that can tell us what to do properly in treatment. Okay. So both sides have a role. Number 3, biopsychosocial history. Think about bio like biology. That can be genetics, that can be developmental history, that can be previous diagnoses, that can be medication, that can be, also children diagnosed dyslexia, things like that. But think about medical history, seizures, head trauma, things like that. And then psycho, in terms of the way that we think, our mind, how do we see the world, what we've been exposed to. And then social is our relationships, our interpersonal relationships, our family relationships. Okay. Number 4 is, what is your treatment history? How many times have you been to therapy? Did you finish? Why didn't you finish? I don't want to hear, like, I'm not saying this to a client, but what I don't want to have, let's just say supervisees say, well, they just said it didn't work out. Why didn't it work out? Why did they prematurely terminate? Because what we may find out is some people prematurely terminated because it wasn't a good match. They cannot tell the therapist. They didn't Feel like the therapist would understand. I don't know. But then sometimes it could be simple things like, I don't want to pay the no-show fee. What? Okay. So treatment history, mental status exam, you should know what that is. Screening tools to consider, we'll go over that. Risk assessment, safety planning. Even if the person is coming in for something that has nothing to do with safety planning, you still need to ask questions about their history and current status. Telehealth specific intake items, yes. There is a list of things that you should be asking because we're going to talk about it. There are limitations to what you can and cannot see via telehealth. Okay. Telehealth is like I'm talking right now. Can you see my whole office? Absolutely not. Thank goodness. Right. But not thank goodness for something that you may need to observe with the client. Okay. So red flag presentations, diagnoses and clinical formulation, treatment planning, medication and medical coordination, like with a medical doctor or psychiatrist, collateral and releases. It's not just with kids. Documentation integrity check. Okay. So that is more looking at your quality assurance. This is not an exhaustive list, but if this list made you double check, like, I don't got about 5 things on here, we got a problem. Okay. So let me now go over documentation workflow. So let's talk about how to actually get your notes done, because before I get into in depth the case, I do want to highlight that therapists that I've encountered with, their biggest complaint is documentation. Complaints. So let's talk about how to get the notes done. I'm gonna give you these tips. So one, documentation, we know is not just a clinical skill, it's actually a workflow skill set. Okay. So if you know that writing documentation, not you being able to articulate what you need to put in the notes, but your ability to set aside time for time management purposes and be proficient with your note taking, if you know that that is an issue for you, you need to stop pretending, stop operating out of pressure, stop waiting until it's too late, and build up a routine for yourself. So the same way that ladies, you put on the calendar, you need to get your nails done, is the same way that you need to put on the calendar to get your progress notes done. If your life operates like me, busy mom, busy wife, life, everything in the middle, okay, I need to put certain things on my to-do list. So like on my to-do list, it actually says when I have an individual client, do they notes. I put that separate from see my clients, because not all the time will it be back to back. Also, with building out a routine, one thing, like I said, that I did early on in my private practice is that I set aside a documentation admin time or day. So for me, because of my work schedule at a 9 to 5 at the time when I was building out my private practice, I did work on Saturday mornings. My day was over on average at 12, maybe 1 if I had a kid in sports. And so I stayed 1 to 2 or 12 to 1. I blocked myself in. I did not scroll on social media. I had already ate my lunch. I am good. I did not leave my physical office, because by the time I start working at home, I already built up the habit. I don't leave my home office unless I'm done. Why, parents? Why, busy people? Because as soon as you go upstairs, it's over for you. You have too many distractions. My family knows when this door is closed, do not enter. Even if some of y'all have been on calls with me where there's a knock, that's probably because I'm at home with my kid by myself. Okay. But even the knock is light. It ain't boom, 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 because he either knows that I am recording or that I am teaching a class. He don't understand what therapy sessions are yet. So I just say I'm teaching a class. Okay. But you do want to set aside dedicated time to make sure that all of your notes are done. Okay. Other tips, if your time, for session tends to run over, meaning you set aside a 45-minute session, a 50-minute session, but you look up and your session started at 9 and it's 9:55. And you know that you didn't schedule for 9:55, you scheduled to 9:45. Okay. I want you to account for certain people, if you don't fix your boundaries, are going to go over. So clearly fix your boundaries, but also fix your schedule. So that's why I say time blocking does matter, so that you can set aside time to not rush through your documentation. Because again, I'm not in the room. I'm not in a counselor's or therapist's head related to this case. But what I can tell you in the mental health field is that we are not setting aside enough time to be able to do documentation. So I would recommend, and this is on a case-by-case basis based on how heavy and emotional a client feels after they've left the session with you, because they feel relieved and you feel like, oh my gosh, I was good until this. And sometimes we can't predict that their check-in will come with all this baggage. But if you start noticing a pattern, then you can do a couple of things. You can switch around your schedule if your clients are open to it, but no more than 3 clients back to back. Some of y'all trying to like hit that 10 to 15K month, and you're putting that above your care. Okay. So my max is 3. It didn't matter what kind of clients I was seeing. I needed a 1 hour, maybe even a 2 hour break, depending on the time of the week, the time of the day of the week. Because if I'm telling in on the end of the week, let's be real, some of you are tired. Okay. Some of you have other jobs, you have other responsibilities. You have to understand yourself first before you start plugging clients into your schedule. I'm talking about this because all of this is related to why therapists don't do their progress notes on time and adequately. Okay. And so, depending on the client's presentation, your energy, session intensity, and even whether you're doing telehealth, I would highly recommend that you see no more than 2 to 3 clients back to back. So, what is that supposed to look like when you're not seeing clients? Well, you build in, if you have more clients that day, a 1 to 2 hour break in between after those sessions. I've done this at a physical office, I've done this in my home. So, that break is not just for let me use a bathroom, let me eat, let me drink. It is for a reset. It is also for you if you need to catch up on your notes. Okay. So if you do not plan time for a proper documentation, you are planning to fall behind, period, point blank. And I can guarantee you, oh, I'm going to do them next week. You're not, because next week going to turn into next week. Next week going to turn into, oh shit, it's December 12th. And I'm trying to be off for the rest of the year. Well, how is that going to feel when you walk into the next year and you're not done with your progress notes from last year? You have over 25 cases that you need to close that are either old clients prematurely terminated or just was a consultation and nothing else. Close out everything belonging to that client. Let's be real. So now let's talk about the big, pink elephant in the room, telehealth and AI. Okay. So telehealth plus AI support. I want you to use AI as a tool if you desire, but I really would like you to vet the tool. Okay. Vet the tool. So, documentation workflow for vetting the tool. Okay. Is you want to vet the tool if it's given to you on your EHR platform or on a third party platform. They will give it to you as an option, as an add on. Sometimes, a lot of times, it's free, but you do want to make sure that anything you use is HIPAA compliant. You also want to make sure that you understand where are they storing it? How long does it get stored in the cloud? What is the cloud? Where's the cloud? Okay. And who has access to the cloud? When I was approached, this was 2 years ago, to do some brand deals with AI systems for therapists, I really just feel like people just Googled who has an audience for therapists. They emailed us. It was a personalized email. I did a Zoom call and I had 5,000 questions that I asked these people. And the problem is the representative that came on didn't even think about the cloud. They didn't even think about, oh, a client will ask, where is this information stored? And those answers were all, I don't know. So I said, okay, I'm gonna give her the benefit of the doubt. It's new. So when you do know, come back and find me. Guess what? She emailed back. She emailed back the brand collaboration, but she couldn't actually answer my questions. I believe in alignment. I'm not going to represent a company in which I'm going to pass that information on to you all therapists, and then you expected me to vet it. No, right? So I didn't even pass that information on, nor did I use it. Okay. So vet your HIPAA compliant platforms. Also make sure, again, you know where it's stored, and also make sure your informed consent or a separate telehealth consent and AI tool consent is part of the tools that you're using. So if you're using AI and you have not talked about it with your client, you have not documented it with your client, we got a problem. Okay. So if you are using these tools, make sure the client, I recommend a sign off so that they can't say they didn't tell me. So make sure the client signs off that your paperwork clearly addresses this. All you have to do is either create a particular AI supported document, which some EHRs may already have it for you embedded. So don't go pay for this in an online store. Just go see what your system already has, like SimplePractice. The link is below for an extended trial. Is with SimplePractice, that's what we teach you in our coaching programs. They create these forms for you. Okay, so go and look in the library first and make sure that you embed it in your intake documentation and send it out to current clients that did not sign it, which means you need to be keeping up with who has access to what, meaning who has signed what. Okay, so our goal is not to avoid technology. Technology is here, it ain't going nowhere. It is coming. So the goal is, though, to use technology in a way that protects your clients, protects you as well, protects your client's medical background, their chart, and of course protects your license. Okay. So if a tool helps you document more clearly, because maybe you can talk it out, but you're like, I need to add in some more psycho jargon that applies to the diagnoses, but I'm just going to talk out what I saw. I'm going to talk out what I observed. I'm going to talk out my plan, but you need it to sound consistent across all of your notes, right? Convenience should never outrun compliance. Let me say that again. Convenience, meaning I need to write this real quick. Okay. I got to go somewhere over the weekend. It should not outrun compliance. You still need to do your ethical due diligence and, of course, protect yourself too. So, a big loophole in mental health providers is that we forget that our malpractice covers things as a resource, even if we need to consult before something comes up. So, I want to remind you to protect yourself. Always keep your clearly malpractice current. Okay. Never let it lapse. Okay. Understand what is covered, understand what is not covered. This should be for all your insurances, depending on what panels you're on, what state you're in. If you do anything else that requires certain insurances in your city, county, or state, make sure you understand what's covered and what is covered for your license. Okay. So, one of the biggest mistakes that I see therapists, you know, underutilizing a lot is not utilizing the resources that you already pay for. And then because you don't pay attention, you go out and you buy more. Okay. So most malpractice insurance plans, they have access to attorney or legal consultation or assistance or linkage, but you have to call them. Okay. When I was growing a group practice and I had questions around the legalities in California as a clinical psychologist with bringing on marriage and family therapist associates, they were called interns back then, social worker interns, and pre-doc, I needed to understand W-2 versus W-9 beyond what a tax person told me. And so I wanted to see what did I need to do to set it up for my malpractice, because guess what? In California, I had to add all of my supervisees to my malpractice. It wasn't a big investment, but it was still protected, okay? So also, if you run into, let's just say, a difficult documentation issue, a difficult ethical question that you're thinking about, you've talked to your therapist friends, but you're still not getting what you need. Maybe you need a release question, like, should I be releasing this information? Maybe you get a subpoena, which I'll get back to at the end when I tell y'all what happened in court, or a high risk, like this case, clinical situation. Use the resource that is already covering you, that already is familiar with protecting your license. Do not automatically go searching for a lawyer on your own first. Go through your carrier. They are the ones that cover your license. And consultation should not only happen after something goes wrong. I think that's another thing that we can learn from this case, is that I'm not saying that this counselor, this therapist, whatever the title is, did not do that person's due diligence. We're not in their shoes. So don't badger another clinician. You don't know what happened. Yes, they are testifying, but keep in mind, lawyers have a way of asking particular questions, and they will stop you even with a long explanation because they got the part of the answer that they needed. Okay. So we're not here to judge anyone, but we can learn from it. Okay. So consultation should happen while you are trying to make the call. Let's just say if this situation had been presented and you're like, I don't know if this person should be having her kids. I need to consult. So maybe you find a more seasoned provider, you consult with them, a therapist friend in your circle, but don't forget to consult with your malpractice. Okay. So let's talk about how therapists need to wake up, and let's pull in this case. So why bad news makes therapists uncomfortable. Okay. And definitely why it makes the public uncomfortable, because this is another thing added on to the shenanigans we had already talked about on this YouTube channel and this podcast 2 months ago in terms of licensure and all those things. And so it makes the public uncomfortable, and it puts, to me, our field in another layer of jeopardy. And so as mental health providers, we identify clearly with the provider first, like, oh man, like, I hope that won't happen to me. And then you start to think, like, what could she have done? What did she do? Do we know the whole story? Then you may or may not have watched a snippet or parts of the trial or the testimony. I know I caught a couple of snippets, and I was just like, this sucks, right? So most of us have made a judgment call under uncertainty, at least at one time in your career. There was a time where you were presented with a situation, you made a judgment call because you made the best decision that you could at that time. Okay. So avoidance feels protective. When we avoid things that we need to fix or get support in, we feel like we're protecting ourselves, but we're not. Okay. Closing the tab. When you think about your laptop, actually, those of you who are on your phone or you're on your laptop or computer, I want you to look. Don't swipe off, but like, ask yourself, how many tabs are open at the top? 20, some of y'all 50, right? So closing the tab on something like, oh, that session is done. On to the next. Sometimes feels safer than actually auditing your charts. This is why if you're in any of our coaching programs, yes, I'm going to continue shoving down y'all throat like proper quality operating systems and documentation. Why does she only teach about that? Why she won't teach more about marketing? What are you going to market to? For people to come to your practice and you can't keep them? You can't even document the ones you got, right? And so discomfort is the signal to look closer. If you start feeling uncomfortable about something, if a situation comes up in session and you're like, I wonder where this is going, I wonder what else they're not telling me, do not look the other way. You need to be up on your paperwork. So number two, just some basic document basics during the intake. And I've aligned these with ethical codes 6.0102 and then 3.10 for reference. Okay. So, I love to back on myself with like a dissertation, like references. So this isn't an exhaustive list, but we shared some of this earlier. You got to get a thorough, even with adults, biopsychosocial history. And what you will realize when working with adults is that if they're curious, they will actually go back and ask if they have access their parents and caregivers. I know mine do. My clients do. They're like, oh, I didn't think about that. Let me go ask my mama. So it's pretty cool. And then they'll bring it back, like a little book report. So biopsychosocial history. And then, of course, thorough understanding of the presenting problem. With every symptom, you need to know the onset, duration, and frequency. Write that down. Okay. You got to understand the treatment history. Are there any, please ask this in 2026. Are there any current providers? Ask that during the consultation. I have found that because of the easy accessibleness of telehealth services and these platforms showing a lot of therapists, there are some clients who may shop around for a therapist, which is fine if they're doing it during the consultation process. But sometimes they already still have a therapist. So you do want to ask, hey, if you currently do have a therapist, ask them why are they leaving and what is their plan on departing. And what I've educated my clients on, there is something called a good goodbye. But I do want to talk to them about why do they want to end with that clinician, because I'm not trying to talk them into seeing someone that they are no longer aligned with. But we don't want to promote clients opening up their Pandora's box over and over and over again. Okay. So find out if they see current providers, including psychiatry, any type of signed releases that you need to get to talk to other providers. Now, again, working with adults, I've had some adults that refuse to give me information, and the curtain is always pulled back because literally those clients who had refused to give me, like literally outright refused to give me their previous provider's information, those are the clients that actually did not work out. It's less than 5 over the last decade and a half. But those are the clients that did not work out because what started to apparently show up with the other therapists that then helped the client see things from a different perspective, the client did not like that. And so my thoughts are, if one clinician shows that to you, 2 clinicians show that to you, 3, 4, maybe more show that to you, it's probably something you may want to work on, And some clients don't want to do that. They just want to start from scratch and act like things didn't exist. So if you're a patient, if you're a client of therapy, be open with your therapist. Of course, you want to do the mental status exam, informed consent, including telehealth consent. If you want to include social media consent, that's fine as well. But document what you asked. I should have highlighted that in red. Document what you asked from a little clip that I saw online. Even if someone did not answer, and it's pertinent to their symptomology and mental health, if it's pertinent to the mental status exam, what you're looking at versus what they said, what you're observing, their affect versus mood, okay, you want to document that and put down, they weren't responsive. You asked 3 times, okay? All right. Number 3, first session risk assessment, and some clients need more. So we all know SI and HI, homicidal ideation, suicidal ideation. We should live in a world now where, not that this is a normal conversation, but we should not be afraid to say these words. Okay. They're out in the public. And so when someone presents with ideation, okay, meaning they're thinking about it, you want to find out, and they shared it, you want to find out their intent, their plan, their means, of course, any prior attempts. Okay. You do want to use certain type of tools. This is not an exhaustive list. I just pulled some from APA, but we should all be familiar with the PHQ-9, the GAD, the Columbia protocol. That's a different one that some people aren't familiar with. A lot of you may be familiar with the ones you learned at your job. and or ones that you use in your practice. You have the Edinburgh Postnatal Depression Scale for postpartum populations, along with others. If postpartum is your expertise, you do want to, I would highly recommend that you make that part of your CEs. Okay. If you have a specialty, which all therapists should, but your specialty should lead you to doing certain CEs. Okay. Substance use screener. That's something that sometimes after leaving a job, you just forget to ask. You just let people come up with, oh, I smoke weed. Well, is weed like the only thing they do? Is that the only thing they've done? Okay. So psychosis screening, this may not be for all clients, but if symptoms start to come up, it's nothing wrong with asking questions. Disorganized speech, if we're looking at symptomology, hallucinations, delusions. Sometimes delusions. I've worked with populations that are very high over there in that area. And what's often tricky about delusions is that they are based off some percentage of real reality. And so they very much sound real. And that's a little scary because you don't know what's real and what's not because you ain't in their past. Okay. So that's why it's important to consult. And then, of course, paranoia. Okay. If these things come up later, you can always go back and do a risk assessment. Risk assessment are not just for the first session. A documented safety plan. Anytime risk is endorsed, you need to do a safety plan every single time. You're not going to say, oh, we assessed it 3 months ago. I don't care if you assessed it last Saturday. You got to do it again. Number 4, presentations that are automatic red flags. So after looking at this case and then other things that have come up just in the media across the years, is this is not a long, exhaustive list again. But we know as providers, there are certain classifications of symptomology and diagnoses and history of such that may automatically just put a place card in our brain, ideally. All right. So any active or reported past psychotic symptoms. Now, sometimes therapists may not recognize this, and sometimes, unfortunately, it's mistaken for bipolar because you have no experience. You didn't get any internship hours, rotations working in a hospital or clinics to be able to see the difference. Okay. Rapid onset of postpartum mood symptoms. You may just so happen to be a therapist that works with professional women. The professional woman you serving got pregnant. She had a baby. She starts experiencing postpartum. If you want to continue to serve her, I would suggest you start reading on postpartum. Okay. Access to means plus means specific ideation. We're talking about the previous slide, suicidal and homicidal ideation. Fast medication changes without close up. Without close follow up. So clients are going to tell us how they are. Clients are going to tell you their medication, their dosage, how long they've been using it. Ideally, you should know, when's their next psychiatry appointment, even if it's at a hospital. You do want to be careful, though. This is just something that I learned working in the state, okay, is you do want to be very careful about how you document on something that is outside your scope of practice. So in California, they are very rigid with talking about substance use. Like we cannot even create a treatment goal when I used to be at my jobs on substance use. They need to go to a substance use counselor. That was a law that was passed years ago in California. And then also with psychiatry, I can report what the client said, but I should not be doing any treatment around medication. At best, I inform the client that I'm going to consult. Let's just say they're biting their nails or something like that. That happened with me and a kid client at one point where the kids start biting their nails, and I didn't know what it was from, but we were talking about some bullying at school. So I didn't know if it was like an anxiety coping skill or something like that, being uncomfortable, but I knew something was off. And so something told me, listen to your gut, call the mom. So I called the mom or sent her a message through the system. I'm like, call me. So we talked for about 15 minutes and I said, hey, this is something that I noticed throughout the whole session. He also said that he's been doing it for this long and it started here. Was there any changes at school, at home? And then I just so happened to say his medication. Like I just so happened to say it. And she was like, so nonchalant. Oh yeah. We just stopped giving it to him. What? So I did document what the mom said. And I just documented that I told the mom she not our highly recommend. She needs to consult with the psychiatrist. And I said, out of my scope of practice, but anytime there's medication, you should always listen to the doctor's orders and ideally not take any patient just abruptly off medications because of potential side effects. I didn't say all side effects, right? But that's all I'm saying. But I'm going to reroute that conversation back to psychiatry because that's not in my scope of practice. Okay. Also, minimizing symptoms while collateral reports worsen. So let's just say you're talking to family members, partners, significant others that you got releases for, or parents, and they're reporting one thing about things getting worse, but the person in front of you is like, oh, no, it's good. I'm getting better. You have a discrepancy. That should be a place card red flag. You need to inquire more. Okay. Now, telehealth. This was a big issue in this case. Okay. Telehealth. What it cannot catch. Okay. So look around me right now. Look around yourself. No visual, no visual on the home environment or anyone else present. I mean, I'm not asking you to ask them and to get their camera and move around. But the bottom line is you will only be able to see what they want to show you. Okay. It's very hard to catch also. Like I'm a straighten up in my chair, right? But it's still cutting me off. Like you can't probably even see my hand. I gotta put it under here. So depending on where my camera is positioned, and most people may do it on their phone, is it's hard to catch flat affect. Affect is how somebody appears for the general public. Mood is what you say you are. So a fun game that I do with when I was teaching psychology or when I do like mental health workshops to warm them up, I will say, let's talk about mood. And I'm like, hey, so and so, somebody in the room, like, ask me how I'm doing today. And they be like, oh, Dr. TK, how you doing today? I'm fine. Now, I'm going to ask you, what was my mood? Most people's response is going to be, oh, you got an attitude. Oh, you mad. Oh, you irritable. And I'm going to say, no. And then I'm like, yes. So this is the public's understanding, right? Mood is whatever happens. So my mood is, I said I'm okay. My affect is, a therapist, you should be writing about this in your MSE. My affect is I'm agitated, irritated. And now clearly you want to ask the client more questions to figure this out. So you just don't want to guess, but you can clearly see there's a discrepancy. Okay. So it is very hard sometimes to catch different types of affect and disorganization on a very tiny screen. Now, the pro about using telehealth, of course, is that you have a lot of access. Clients also have access to see people in their whole state, not just in their zip code or where they can drive. And it provides consistent treatment. So that is a pro. The con is reliance on self-report and a video frame. I imagine if I were still working with teenagers or kids, that getting the parents more involved than the little that they wanted to be involved in the therapy room when I was at an office would probably be more difficult depending on the family because they may be at work when I'm seeing the kid. And so one rule that I recommend that you adopt is if a risk does rise, if you can go rent out a telehealth space, there are offices, day offices, have privacy, escalate it to in person. You can choose the frequency based off the risk, but don't just get in the habit of adding just more telehealth sessions. So, for example, when I was seeing a adolescent, he was first being seen in my physical office space out here in LA County, and he was going to be seen on Saturdays. But I had preferred to see him during the weekday because of the presenting problems at school. I wanted to see what was happening in the moment, not just, oh, the week is over now. And now he don't remember half of the stuff. So I went to a school meeting based off a situation that happened. And they actually gave me permission to see him at a school. And that was more consistent for the kid so that I can also collaborate with the people on campus at this new school that he had to be checked into because of his behavior. So what started happening was he would open up to me, but there were certain instances where he wouldn't open up as much. It was by environmental. So at some point, I made the judgment call. It was no, do you want to? It was, hey, this is what I've noticed over the last 2 weeks. When we talk about this category, I noticed that you feel a little timid to like tell me more like you do with everything else. You feel me? And he was like, oh, yeah. And so I'm like, next Saturday, I already talked to your mom. I'm gonna see you at the office. So I'm not gonna see you at the school next week. Next Saturday, you're gonna see me at the office. I kid you not. That kid came into the office. I asked one question. He broke, like crying, right? Not mad, just crying. He was holding it in there for so long. And it like made me cry. I don't like to see the babies cry. And so we talked about that. I talked to him, to his parent about that. And I said, hey, every once in a while, I'm going to need you to bring him in on Saturdays. And we will skip that week during school because I need him to have a safe space to talk. Y'all need to give yourself permission. You have a business. It's a write-off. Go get an office if you need to, because you chose your audience. Okay. So Before I wrap up with the case study and then give you some other tips, I do want to let you know this is only for today. So today is Friday, August 14th. There is a bonus under this video. Okay. It is at a ridiculously almost free investment. This is what you're going to get. It's a simple document, but it covers 1 through 15. And my favorite is documentation and integrity check. But what these are is a list, an exhaustive list of things that you need to make sure you have and or ask yourself what would happen if this were to come up. So for example, do you have documentation related to collateral and releases? Where are they? Like, you need to know where these things are. You need to know that they're up to date. So it's not just a checklist like this. It is, I believe, like 16 to 17 pages or something like that. Okay. So I created it actually just for this masterclass on YouTube. Like, clearly the information is free. But in terms of you having a document to carry along with you to use it as your quality assurance binder, because most of us are working on our own, you can either check out the pinned comment. You can check out, it might be appearing in my store with like a picture, but it's also the link in the description box. Okay. So there is also a bonus tip area in there where I do talk about clinical supervision, because you're not off the hook. Okay. So if you do supervise pre-licensed providers, this checklist does not stop at just your practice, your group practice. Okay. It does include a clinical supervision tip that will help you build some ideas around what you want to train your supervisees on in terms of appropriateness with certain documentation. Now, I do have a clinical supervision library. You can find out that information again beneath this video, because if you are teeter-tottering on, do you want to become a contracted supervisor, like you go get your supervisees and that's it, you don't give them clients, or you are going into a group practice or you already have one, and you are not embedding training, or you got the wrong supervisees, you didn't vet them accordingly, there are some supervision guides and master classes in the description box as well. Okay. So let me tell y'all what happened in court. Let me check on a scale of 1 to 10. How did y'all like the information thus far? Can you please touch on, if you are in private practice with staff, how to help them manage their time for notes? Are you talking about clinicians? So here's the thing. I don't know. I know some people are popping in at different times. I would highly recommend that, just like a job or internship that we have worked on, that you emphasize and design a infrastructure that provides the guidelines and when they need to turn their paperwork in. Okay. So let me just take this down for a second. Okay. So this is something that comes up with our supervisors in our Scale Academy, along with our mastermind group practice owners. As we're talking and I start to notice that they get frustrated, they still ain't turning their paperwork in on time. So I'll be like, all right, what's your guideline? And they'll be like, as soon as possible. That's not a guideline. Like, is it 2 days? Is it 2 business days? And what happens when it does not happen? So 2 things have to happen. You want to create a set of SOPs for documentation and turnaround time. Then you want to, for existing team members, pass out an addendum like a job. Okay. And then you potentially want to talk to them about it to see if they have any reservations and get their John Hancock on that signature line, just like a therapy client, like kind of like a handbook. Do you understand that this is the new policy moving forward? And this also includes now this is supervision or consultation. You need to pay attention to, for quality assurance purposes, how far back behind are they? And then you need to create a plan for them to get caught up. And the reason why I would say just don't outright let them go, because you never gave them the structure to begin with. Now, if you did give them the structure, now my second part is, how are you dealing with that? Because that's another standard operating procedure. Do you have a verbal response to them, then written? Like, see, these are the things that, for whatever reason, therapists, we don't do what jobs did. And then we wonder how jobs either were letting go of people, or people weren't a good match, or some people don't like to be there because of the strictness. That's what people say. It's too strict. They micromanage. Some places that I've worked have very much micromanaged, but some places actually just managed and you didn't like the documentation. Does that make sense? I'm gonna show it. This Sherry. Did that make sense? I hope that helped. Okay. And so create some type of policy get with them and make a plan to finish all their own paperwork, their old paperwork, and then also have those expectations set to move forward and lay out what will happen. And you have to follow through on what will happen. And this is why I tell supervisors and group practice owners, you really got to be careful about what you're signing up for with capacity. So let me just go ahead and do the shameless plug. We are having a boot camp starting on the 17th on Monday. We are going to be talking about assessing your back office systems for capacity to either continue or add on a new stream of income. Because a lot of therapists come to me for these streams of income. I give it to you, right? But at the end of the day, you can't launch it if you don't have the capacity for it. Okay. So let me tell you what happened with this case situation. And so when I was working at the juvenile camp facility, like I said in the beginning, I was called into the supervisor's office. The supervisor was there, and so was the program head. At this time, I was licensed as a clinical psychologist. And the way the facility is set up is that it was 6 camp dorms up to 100 kids, 110 kids. They can sleep, but they never had that many. And what happens as a minor, a child, when they are sentenced, they go to these camps for 3, 6, 9 or more months. But some of these kids, a large percentage, graduate, unfortunately, into the adult system. And I've also been on the side where some of young kids that I mentor are caught up in the system, or they do things to get in the system, and then they graduate into prison. Okay. So I've been to court hearings, and things like that. But at this time, I hadn't been to court hearings. And so my program head, he was a LCSW. He used to work in the camp that I used to work at. That was like probably one of the best program heads I had ever had, right? And he knew the line, meaning he knew what we did, so he protected us. And so he called me in the office and he was like, "Hey, don't you live in?" At the time, I was still living in Compton. And he was like, "You still live by Compton Court?" And I'm like, "Yeah, about 15 minutes away from my house, maybe not even like 7." And he was like, "All right." He said, "I don't know if you're interested, but I'm going to ask you first. On this date, we got subpoenaed my records, and I cannot go. I need somebody to go, and it just made sense to ask you because they saw the work that I was doing. I was over a particular team related to documentation and stuff like that, and my supervisor recommended me. So they wanted me to go in his spot. And so I had to ultimately take the physical chart. It was like this small, it was super tiny. And he said, if you can go, you don't have to be at court until like 8. And I had to be in Lancaster, which is a 3-hour drive with traffic. So he was like, just sleep in, go to court. And he said, if they keep you in there waiting on the judge after 1:30, 2 o'clock, don't come in. Just, we're going to still pay you for the whole day because I'm on salary anyway. And I was like, all right. So he said, but if you're done before lunch, just come back or whatever. But email your supervisor, grab lunch while you out, and then we'll also give you mileage coming back. Cool. So I went in with my chart. I didn't know what to expect. The only thing I was printed out, and he rehearsed with me, is we learned this in ethics class, but we never read it again, is it's a statement. I don't know about heart right now, but it's a statement that we have to read ultimately that says, "Judge, in so many words, I don't want to give you the whole chart." It doesn't mean that we don't want to give them the chart. We just don't believe that they need the whole chart. This is very important in terms of advocating for your clients. And so I said, okay, I was a little nervous, but the chart wasn't that big. I flipped through it. So what happened with this particular person is they were over the age of 18. I'm going to take a stab at it and say that probably is not the right word for it. Sorry. I'm going to take so I think this person went into the adult system and they have to subpoena all of their past records. Okay. That's what I learned in later cases. And so we can't know anything about the case. All we're there to do is turn in the paperwork. So I am the first one to get there. So kind of just sitting around like, oh my God, am I the only one here? And my supervisor says, if the judge asks over 2 times after you've made the statement, get in the chart, because the only thing that's in our chart for getting sentenced to camp, because kids can go back and forth to juvenile hall, but to get sentenced, that is something different. Now, the other thing, when you get sentenced to camp, this is how it used to be. Every kid has to have an intake at each facility they're at, even if they were just in juvenile hall. And once they do the intake, if they're not mandated to do treatment, then we don't have to give them treatment. They have to volunteer anyway. And if they are mandated, they don't want to see us unless they're on psychiatry medication. They can wait until they go home and then see therapy when they go home. But we tell them that doesn't make sense. Start therapy now. So nevertheless, I show up. Within like 15 minutes, 2 other therapists come in and hundreds of documents. One facility, I'm not going to say the name of the juvenile halls, but it's 3 in LA. One of them, no lie, had 2 packets this big. Like the prongs were out of space. The other one had one that big. And I'm just like, this kid didn't went in and out of juvenile hall. Did they live there? You feel me? And so me and the other clinicians were talking, and then the court clerk comes out. And so when they come out, they said, do y'all have the documentation? And so we all had the same. So I guess the dean, or not the deans, the heads, they already had talked. So we were all coming as a representative for this case because it was like 6 years old. So those staff probably didn't even work there anymore. So we all individually, one at a time, read this document. And I'm just like, this is some movie type stuff. So after that, the clerk looked and she was like, I guess she used to. She was like, all right. So she went back to the judge. She came right back and said, the judge said no, turn over the records. And so then I'm ready to turn over mine because I read it again. And she was like, no. And so I'm following my supervisor's instructions. But what we decided to do when we talked is see if we can negotiate with the judge through the clerk to only get the most recent documents. So I'm not telling you what to do when you get subpoenaed. I'm just telling you what happened because this is real life stuff that, our professors teach us about, but you don't really learn it until it happens. So we negotiated for educational documentation to be like, you don't need educational document. We're not LAUSD, right? And so they agreed. Then we said, it was a lot of back and forth for like 30 minutes. Can you ask the judge if they can get the most recent intake written for each facility, because the intakes build off of each other. So it's just one long document, right? Why get 10? And then can you get the most recent treatment plan from the therapist and then psychiatry? So what they're going to get is 2 intakes, the most recent from each facility, from each provider, psychiatry and mental health, and the intake and the treatment plan. And then we said we can negotiate for, now mine didn't have no progress notes except for the intake progress notes, so this didn't apply to me. But we negotiated for the most 5 recent progress notes. You don't need to see everything, right? And the treatment summary, meaning the kid got released, they went home, they went to camp. And so the treatment summary, the court clerk went in the back. She came back and she said, accepted. And I was like, wow, this showed me you don't have to, but you do have to. You don't have to just hand over the chart. And I would highly recommend that you don't, right? Because there is a variety of different, especially depending on where you worked, there is a variety of different documentation that, we chart on, okay? So coming back here, this is just a synopsis of what happened. Like I said, we negotiated the documents that were clinically relevant. That's key, to not hand over the full, file. And together we collaborated. Now, sometimes you'll be by yourself. Most of the time you'll be by yourself. So together we collaborated around what documentation should be turned over. Okay. And so your takeaway from this entire masterclass today, because I know it was thorough on documentation, right? I'm not about to sit here and gossip about this case, but this case raised a lot of questions that you should be questioning. So I want you today, it's Friday. I want you starting next week. I want you to pull your intake packet or your documents online. I want you to hold it up against the standards that we talked about today. And if you want to hold it up to the standards that is in that guide, then you're welcome to do so. Okay. I want you to, for your clientele, confirm your risk tools that are either available that you can use, even though you may not need them right now, and that they're current, and that they maybe need to be used every session or infrequently, depending on your population. Also, if you are not sure what your malpractice covers, you may want to pull out the document. If you want to consult with someone in your malpractice, call. It's a phone call or an email away. Okay. So what I want you to take from everything is that, for myself, like my introduction said, I am a licensed clinical psychologist. I thrive off of quality assurance. I thrive off of good customer service. But that is my expertise in this field, which has made me really good with systems in business, which is what I teach with the operating systems. That's why I'm inviting y'all to that boot camp on Monday. It is free. but you do have to pay with your time and attentiveness. Replays are available for a very limited amount of time. It is only 3 days and it is 3 different topics on all 3 days. Okay. But I coach to this. This is in my veins. Okay. So I am the operations therapist, coach, and mentor. It doesn't mean we don't talk about marketing, but we don't have room for marketing when you have no room to build a business. Okay. So I want your business to stay open beyond the typical 3 to 5 years. When people throw in the towel, they get burnt out, or unfortunately, something happens. Okay. But I do believe that the lens of this particular case, it has brought up a lot of questioning with therapists. And so, if you don't mind, I would love to hear from you in the comment box. I want you to comment what's one thing in your intake process that you need to tighten up after this video. And don't just put, I need to do all my paperwork. What does that mean? Do you need to type up the intake? Do you need to update all your clients' treatment plans, or make a list, or look at your systems with your reminders? Who needs a treatment plan by the end of this month? What cases need to be closed out because you ain't seen that client in over 90 days? Okay. But subscribe to the channel. Remember, we don't gossip here. Okay. We educate. We are also here for consumer protection. So that's why I present things in the way that I do it. Because one, I'm not nobody's therapist on here. So I'm providing things for psychoeducational purposes. Okay. One more time for the record, just because I got to do it for, some commenters, is this video, this masterclass is strictly psychoeducational, meaning it's education for the public and for providers on mental health, psychology. Okay. It is not commentary on any specific provider and cases, any patients, any case outcome. It's not legal or clinical advice. And I am not your psychologist. I may be the YouTube psychologist, but that's just for information. Okay. So I want you to start being more diligent. I want you to pay attention. And most importantly, y'all need to stop getting so comfortable. Okay. If that's what I should have named this. Like, you too comfortable. You too comfortable. Okay. So I hope that you thoroughly enjoyed it. Let me make sure I went over all of the announcements. So the 3-day boot camp, it is called Beyond the Therapy Room. It is for mainly those who already have a business. I will say, because I've done some in the past, for all mental health providers, if you do not already have a practice, you can come, but a lot of things will not apply to you. It's going to go over your head. And I am not in a season of just giving you more information, because we will be doing application, meaning you're doing work with me, which is why we're meeting on Zoom. We're not meeting on YouTube. We're not meeting in a webinar. I want to see you. If you can turn on your camera, be attentive, and I cannot wait to connect with y'all. So I'm going to wrap up. That is my Fridays live stream, or our news and mental health. By all means, to the public, can't diagnose nobody, okay? But to the public and to mental health providers, if you have any other topics related to showing up as a business owner and documenting our way to success, I would highly recommend that you jot down your questions below. And most of the time when I get a stream of questions in, then that will, nudge me